Association of Ontario. I'm one of the program managers who oversees the Champions Network and delighted to be with you today. This presentation is brought to you by the RNAO. We are the Professional Association for Nurses, and we are soon to celebrate our 91st birthday at our upcoming AGM. The RNAO, as you may know, has a signature program called our International Affairs and Best Practice Guidelines Center, and that's where we develop and disseminate best practice guidelines. We have a best practice guideline that focuses on smoking cessation, and as part of that guideline work and initiative, we hold regular webinars that support capacity building for all of you involved in the promotion of tobacco and nicotine cessation and harm reduction. So I'm very happy to have all of you with us here today. We are wanting for our webinar to be interactive and engaging, and we encourage you to type in any questions or comments that you have for our speaker today in the chat box during the presentation. And we anticipate that the presentation will take about 40-45 minutes, and then after that time, then we'll have a chance then to address your questions. And in the event that we run out of time, then our presenter has agreed to respond to any of your questions in writing, and we'll do some follow-up. So I'll tell you a little bit about our speaker. It's Jen Tiberio, and Jennifer has been since 2014 working as a tobacco and nicotine intervention specialist here at RNAO, and she works with healthcare professionals and organizations to implement our best practice guideline on smoking cessation into organizational practice and policy. Jennifer's background, she has a Bachelor of Science in Nursing from York University in 2006. She has a Master's of Nursing from the University of Toronto in 2008. And then in 2010, she received her Primary Care Nurse Practitioner Certificate from Ryerson University. She is also teach trained and received that from CANH in 2011. And then beyond that, she's worked primarily in family practice from 2007 to 13, where she developed and ran a comprehensive smoking cessation program. So delighted to have Jennifer here today. And as you can see from the screen, her focus is on the 6 steps to implementing tobacco cessation best practices in your workplace. So she's going to be discussing what are some of the challenges to implement tobacco cessation best practices in healthcare settings. How can these challenges be overcome? How can sustainability be ensured? So she's going to look at the 6 steps to ensuring successful implementation and sustainability of tobacco cessation best practices in healthcare settings. And she's going to be using our Toolkit, Toolkit Implementation of Best Practice Guidelines, 2nd edition, to be used as a roadmap, if you will, to guide the discussion. So I'm very happy to be introducing my colleague, Jennifer Tiberio. Thanks, Jen.
Great. Thank you very much, Catherine, and good afternoon to everyone on the line today. Thanks for joining us on today's webinar. As Catherine mentioned, I will be discussing those sort of 6 key steps to successful implementation of a tobacco cessation program within your healthcare setting. So really regardless of what healthcare setting you might be working in, whether that might be hospital, primary care, long-term care, public health, really want this to be relevant to you regardless of your workplace environment. And also it is focused not only at individuals who might be interested in starting a new tobacco cessation program within their workplace, but also those individuals who currently have a tobacco cessation program to some degree within their workplace, but are maybe looking at expanding upon that program or offering new components to that program, or who may be interested in just looking at how do I evaluate the work I'm doing, or how can I sustain the work that I'm doing over time. So I really hope this webinar will be relevant for sort of a wide range of backgrounds and stages of program implementation. So just in terms of today's objectives, so we really will be talking about those 6 key steps to best practice guideline implementation, and then how do we take those key steps and how do they apply when we're specifically looking at implementing tobacco cessation best practices. So the two primary resources that I'll be referring today, as Catherine mentioned as well, is our best practice guideline, integrating smoking cessation into daily nursing practice, as well as our toolkit on the implementation of best practice guidelines. So the toolkit will really be, as Catherine mentioned, that roadmap that really outlines those 6 key steps to implementation, and we're going to sort of break down those steps one by one and discuss how we can achieve success along that continuum, along that path of those 6 key steps. So just to do this, just to start with this, so what are some of the reasons why we would want to ensure best practice guidelines, or BPGs as we refer to them in short? Why is it important that we implement our programs based on what best practices tell us? So just looking at the toolkit itself on page 7, and just wanted to let everyone know as well that you can access free copies of both the toolkit and our smoking cessation best practice guideline online. They are available as a free PDF download, and hard copies are also available to be ordered with just the cost of shipping that we charge for those resources. So page 7 of the toolkit does talk about what some of those reasons might be. So to start, just to sort of look at delivering effective care based on what the current evidence is telling us. So we just want to be able to deliver care that's accessible and impactful for our client population. And so we may be looking at different ways to achieve this. So we might be looking at ways that we can maybe increase the number of cessation visits to our clinic. We might be looking at how do we increase the number of referrals to maybe more intensive cessation interventions for clients, or looking at wanting to increase quit rates or quit attempts within our client population. And looking at best practices can help us achieve some of those goals. Another reason why we would want to implement best practices around tobacco cessation might be around resolving a clinical problem. So perhaps one group of healthcare providers in the organization do things one way, and another group do things a different way. And is one way more correct than the other? Is there a way to maybe sort of more standardized care and ensure everybody is receiving the same messaging? It may also be around sort of clinical problems, for instance, looking at clients who have chronic illnesses and are also concurrently smoking. So how can we resolve issues around potentially falls in long-term care as maybe clients go outside to smoke, or the relationship between tobacco use and good blood sugar control in diabetic clients, or relationships between smoking and exacerbations of COPD. So it can also sort of help to resolve those clinically based problems as well. And the next one is really just looking at achieving excellence in care overall, so that everyone who enters the healthcare facility might be then asked about their tobacco status and have that documented, and that everyone who accesses the clinic or the hospital has that same opportunity to access the same supports. We may also want to use best practices to introduce an innovation. So if we're looking at building upon a current cessation program, we might want to look at adding RNs dispensing nicotine replacement therapy, or starting group cessation programs, or maybe even creating new documentation templates for staff to use for both initial cessation visits and follow-up cessation visits. So best practices can help to guide that development. And also looking at ways to eliminate those non-best practice interventions as well. So the evidence can really speak to those interventions that we should be promoting, things like the use of nicotine replacement therapy to assist with the cessation process, and then looking at maybe not giving the messaging around other interventions that the evidence does not support. So things potentially like acupuncture or laser therapy, where at this time we don't have the evidence to support their use in successful cessation. And then as well, looking at the evidence can help to create a work environment that really does enable overall clinical excellence within the workplace. So it may start in one program, so delivering an evidence-based cessation program, and then that may spread to other programs within the organization where best practices are really used to guide the care that's given to clients. So just some reasons why we might be looking at ensuring our programs are based upon the best available evidence. And then just in terms of what is our toolkit, our implementation toolkit. So it was originally published in 2002 and then revised subsequently in 2012. And it was really a way to help healthcare providers to take the information contained in any of our best practice guidelines and really then take that information and start implementing it in practice. So it's that way to bridge that knowledge to practice gap. And help to prevent what we sometimes refer to as shelfitis. So we've got that best practice guideline, it's sitting up on the shelf, but how do we really start to give legs to that evidence and start actually utilizing it in everyday practice? So the toolkit helps us to sort of walk through those 6 key steps that we'll talk today to really put that evidence into practice. So just an overview of what those 6 key steps are, and we will delve into each of the 6 key steps more in depth as we go along the rest of today's webinar. So the initial step is really identifying the problem. So looking at what's going on within your workplace and how can we improve what's currently happening. So maybe that might be starting a cessation program, it might be growing or improving an existing cessation program. And it may be something like noticing that some staff or some departments within your workplace are really, really good about asking and documenting about tobacco status, while the same might not be occurring in other areas within your organization. So it's really looking at what is the problem and what is it that we would like to improve to actually improve client outcomes. The second step is adapting the knowledge. So it's ensuring that you're choosing a relevant guideline that is applicable to your local population, and that you're applying it at the right time to the right audience. The third step is assessing the facilitators and the barriers towards guideline implementation. So it's really there. It's a way to sort of start thinking about what are some of the supports that are already in place that could help me to start or grow a cessation program, versus what do I project maybe some of the challenges that I will need to overcome when implementing changes to my program or to start a program. So these may be things like staff attitudes, lack of monetary resources, or lack of time. So really starting to think about what some of those challenges might be, as well as what some of those facilitators might be. The next step is then tailoring implementation strategies. So we've got the go-ahead to start implementing our program or implementing our changes. So what are the actual strategies we're going to use to get staff on board to really start using this guideline in everyday practice? And then the next key step is implementing an evaluation strategy. So always really important to be able to evaluate the impact and the effect of the work that you're doing. So we'll be looking at some of those evaluation strategies. And then the next step is just sustaining the knowledge over time. So once a program has been implemented, oftentimes other priorities may then come up within the organization and focus shifts to other concerns. But sustainability is really looking at how do we sort of keep this program rolling forward when the spotlight may have shifted within the organization. So we'll review those steps one by one as we go along. This is the knowledge to action framework that you'll see within the toolkit itself. And it's just a visual way to look at those 6 key steps to implementation. So within the toolkit, the diagram or the framework used is from a book entitled Knowledge Translation in Healthcare, Moving from Evidence to Practice by Strauss, Tetreault, and Graham. So the actual diagram I'm using today is a little bit different from the one in the toolkit. It's the same information, just visually depicted, slightly different, just for ease of reading up on the slide today. So this particular diagram was from one of the authors of the book I just mentioned, from an article that was written in 2006 called Lost in Knowledge Translation, Time for a Map, and that's from the Journal of Continuing Education, and that's where this particular diagram comes from, and we're going to work our way around sort of this circle as we go through the various steps. So to start, we're going to talk about identifying the problem. So oftentimes when identifying a problem, this can occur in one of two ways. So either there's been a clinical or workplace-based problem that is noticed by staff, or a healthcare professional might come across or become aware of a new best practice guideline and start to think about whether current practice within the organization is in line with what this best practice guideline is telling us. And that sort of starts the ball rolling oftentimes. So to really start thinking about whether what we're currently doing in our workplace is in line with best practices, a very helpful tool can be conducting a gap analysis. And gap analysis is talked about in Chapter 1 of our toolkit, and it's just a way to look at where we are currently versus where where should we be if we are practicing and creating a program in line with best practices. So looking at where those gaps might exist within your program. And it can really help to sort of focus down and see where we already are currently doing things very well, but also where there might be room for improvement going forward. Some gaps that might be noticed may also just be due to the fact that some of the recommendations in the best practice guideline are not really applicable to my workplace. So a tool that is quite helpful is this gap analysis worksheet. So the one currently up on the screen, it takes the first 7 recommendations within our smoking cessation best practice guideline, which are the 7 practice recommendations, and those are noted 1 through 7 on the left-hand side of that worksheet. And then from there, you'll see on the right side the columns met, partially met, or unmet, with room for comments beside that. So it's a way to just sort of sit and think about one by one these recommendations, and then to just sort of check, okay, are we doing this in our workplace? So I can tick off met. Are maybe some staff implementing this particular recommendation, but others aren't? Maybe some units within the workplace are, others aren't, and that would be a partially met recommendation. And then the unmet recommendations would be those where this is really not occurring anywhere within the workplace. So it's something that can be done either as an individual or oftentimes when implementing a new program or growing an existing program, an implementation team is formed. And so this might be an activity the implementation team would do as a group. So it really helps to outline and highlight, where those gaps exist. And after completing a gap analysis, looking at, okay, where do we start? So we're doing a few things really well. We've met those recommendations, while others might only be partially met and some are unmet. So oftentimes we talk about going for the easy win or maybe the quicker win, and oftentimes those might be the recommendations which are actually partially met. So we may already have a number of staff on board already implementing these recommendations, and that might be a great way to start. It might be a little less daunting, whereas the unmet recommendations may take a little bit more time, a little bit more effort to get everyone on board. So it can be, even just from a motivation standpoint, a little bit more motivational to start with those recommendations that you foresee as being a little bit easier to implement. So, and it also helps to sort of highlight where the successes and the wins are within the organization, a way to sort of highlight where things are going quite well in terms of implementing these best practice recommendations. It's also a great document to have when comparing what's gone on over time. So we do our initial gap analysis to see where we are currently, and then we come up with our plan for moving the partially met and the met unmet recommendations into the category of being met. And so we can compare the document from baseline to maybe 3, 6, or 12 months down the line, and it's a great way to see how far we've come and what we've achieved in that period of time. So it can, as I said, be done either as an individual activity or in sort of an implementation team. Great way to see where we are and what we need to do to get to where we'd like to be, which may ultimately be wanting to implement all 7 of those recommendations. And then the next phase in the cycle is then adapting the knowledge into clinical practice and ensuring that it's relevant within the local context of your organization. So when adapting knowledge, there's 3 sort of realms to look at. So there's the organizational infrastructure, there's the stakeholders themselves, and then there's the resources that are available. So we'll touch briefly on those 3 tenets. So looking at the organizational infrastructure, so is now the right time to implement this guideline? In terms of the best practice guideline itself that we're using, is it relevant within the local context of our organization? Can it be adapted to our local context? Or is the guideline far too specific? Is it based on a population that is quite different from our own population, so as not to be maybe useful in this context? And there is a resource that can be used to sort of help us assess whether this best practice guideline is applicable within our local context, and that's the ADAPT collaboration. They've developed an approach to guideline adaptation. So it kind of outlines a number of steps to be taken just to ensure that the guideline and the recommendations within that guideline really are applicable to the current context and current setting. And you can find that online at the ADAPT collaboration. But once we feel certain that this guideline is applicable to our local context, then we want to start thinking about who our stakeholders are. So in terms of actually getting individuals on board who will support us in rolling out either a new tobacco cessation program or to help us expand upon and improve an existing program. So stakeholders are those individuals who have a vested interest in what is going on. So they are people who are either going to be directly affected by the change or they will be effecting the change. And it's important to look at both internal and external stakeholders, so those individuals within the organization who will be either affected or affect the change, and then those external stakeholders outside of the organization. And then the third category are interface stakeholders. So those are individuals or stakeholders who are both internal and external to the organization. So an example there might be a staff member who works at the hospital but also teaches at the local university or college. And then it's also important to assess the levels of projected influence and support of those stakeholders. So thinking about our stakeholders, who will hold sort of the most influence in terms of implementing these best practices, and who do we project will be the most supportive? And then on the flip side, looking at who might we anticipate may not be very supportive of making these changes, and who might not be so influential as well. And it's important to note that when we start thinking about who our stakeholders might be, we really are projecting in terms of what we think. Well, we think this person might be supportive, but we don't really know until we start the process. So it is, when doing a stakeholder analysis, I always talk about it as being sort of a living, breathing document. It's something that we constantly have to go back to and constantly reassess and update who our stakeholders are and where they sort of lie on that continuum of influence and support. So some examples when we're thinking about who our stakeholders might be, this is a nice sort of chart to start thinking outside the box in terms of stakeholders who may not be just in our immediate environment within our organization, but who might be some of those external and interface stakeholders as well. So this chart can be found on page 37 and 38 of the toolkit. So for instance, it talks about internal stakeholders being nurses or physicians, dietitians, social workers, occupational therapists. External stakeholders being those who could be even the mayor, it could be RNAO, the College of Nurses, universities, professors, and then interface, as I mentioned, that sort of bridge both internal and external domains. Also important to think of stakeholders as individuals, groups, and also organizations. So not just an individual nurse, but a group of nurses on a particular unit. And then organizations such as unions or other community partners. So stakeholder analysis is often something that might be done at the outset with your implementation team, or again, just solo, thinking about who are those individuals that will either help or potentially hinder implementation of best practices. And then this is just a bit of a chart that we use when we're thinking about organizing our stakeholders in terms of their influence and their support levels. So you'll see in the upper left quadrant represented by the dog, those are our high fluence and high support individuals. So what we would do is start to think about, okay, who are those groups, those individuals, those organizations, either internal, external, or interface, who I project will be high influence and high support. The quadrant on the upper right are those individuals that are high support but low influence. So we know they'll have a lot of support for what we're doing, but they might not have the influence within the organization to really help, roll this forward. And so it can be helpful just to sort of write the position of those individuals in those quadrants. The bottom left, represented by the crocodile, are those individuals who we project might be low support but high influence. So individuals who have a lot of influence within the organization, they might be in management, they might have access to dollars, resources, but we're concerned that they may be of low support. And certainly that can be a barrier where we'll have to brainstorm ideas to overcome those challenges. And the bottom right are those individuals who are low support and low influence. So really those individuals who may not really care one way or the other if this initiative or these recommendations are put into practice. But important to note that these stakeholders may change over time. So that's why I say the stakeholder analysis is really a living, breathing document that needs to be changed and updated over time. But important to think about who our stakeholders are when we're thinking about who are we going to get on board to support us and where might we anticipate some challenges being. So that's sort of the benefit of a stakeholder analysis. And then as well, when adapting to the local context, is thinking about our resources. So resources being funding or money, human resources. So thinking about within our organization, who are those individuals that are potentially trained to provide either brief or intensive interventions around cessation to our clients? Will we need to train more staff within this program? Are there the funding dollars for us to be able to train additional staff? So it's that talent audit. Where are we currently in terms of those staff who are trained and available and comfortable providing intervention services? It's also looking at resources around education, guidance, mentoring. Can we do a train the trainer session for staff to improve their ability to provide brief cessation intervention? Is there the protected time that might be required away from clinical practice to actually start implementing some of these recommendations? And that's really important, because without that time, it can be really difficult to get some of these recommendations or guidelines as a whole off the ground within the organization. And then looking at those that have sort of the authority with responsibility, so they can book venues, they can access certain resources for you. And so really it's an issue of sometimes being persistent and having that vision and really staying on focus to help sort of push an initiative forward. So those are sort of the three ways when we look at adapting the information or the best practices to the local context. So is the guideline itself applicable? What about our stakeholders? And do we have the resources? And if we don't have the resources, what is it that we're going to need to do to ensure that we have the resources available? And then after that's been completed, the next step would be assessing the barriers and facilitators to knowledge use to best practice guideline implementation. So when thinking about facilitators and barriers, it's important to think about them on three levels. So the individual level. So within staff that you may be working with, what are their attitudes? Are they on board? Is there going to be some pushback? What about the skill level? Do we, as I mentioned before, important to have the right number of staff who are able to provide intervention? What about time? Is there an issue of lack of time to maybe attend education sessions or to learn more about best practices? Is it a time where there's been a lot of turnover within the organization? Is that going to be an issue? Is it maybe to the point where we need to maybe get fully staffed before we start looking at implementing these best practices? And then looking at things like what's the level of teamwork and communication on that individual level, because those could function as a facilitator if communication and teamwork is high, or a barrier if there are issues with communication and teamwork. And then looking at the organizational level. So again, what are those resources that we currently have? So whether it's physical resources like a room to hold a group session around tobacco cessation, funding dollars for maybe changing our EMR templates in terms of documenting initial and follow-up visits. Do we have the equipment, things like maybe carbon monoxide monitors, which a lot of sites use as a feedback tool with clients. So looking at CO levels while they're still smoking versus their CO levels as they're quitting or have quit, and watching that number decrease. That can be a really motivational piece of equipment. Looking as well at workload and the priorities and the policies that are in place within the organization. So is this an organizational priority at this time? Can you get support during this time? Or is there potentially just too much going on within the organization that we may have to park this for a few months and then revisit it? The system level, so looking at government and the regional, national laws, regulations, our Smoke-Free Ontario legislation can be certainly facilitators to assisting with best practice implementation. So looking at common facilitators and enablers, so certainly support through having education and the tools and the resources needed for the job. Looking at the sort of congruence with current practice and beliefs and values with what we're trying to do. So if they do align, that can certainly be a facilitator to implementing these best practices. And then looking at leadership at all levels. So do we have buy-in from management, from our nursing staff, from our allied health staff, even administration, if they may need to change the way they do things, document things, if they're now calling clients to attend group cessation sessions, and that may add a few extra minutes to their day. Do we have buy-in at all levels? And then looking at what some of those challenges or barriers might be. So things like having lack of prompts within potentially like your electronic medical records and charting system. So having that lack of templates or little pop-up windows that sort of trigger you to ask about tobacco use, that may be a barrier, and that potentially could be overcome if changes can be made. If workload is already too high, if staff are working short-staffed, that certainly is a barrier as well, to add in maybe one more thing to their day. And then looking at, resources, and are they limited? Is there lack of trained staff? Is there lack of rooms or resources? And then organizational constraints. So like I mentioned, if there's a lot of turnover, if there's a change in leadership, this can also be a barrier. And then the attitudes and potentially myths of staff, the thought that, well, we already do this, so why do we need to look at this again? Or this is not what I was taught in school, why are we wanting to change this? And addressing those potential barriers. And there's a lot around this in the toolkit as well. So on page 55, there's that overview of challenges and facilitators and how to overcome some of those challenges. And then the next step is, so we've identified the problem, and we've chosen our guideline, and we've done a gap analysis, we've looked at who our stakeholders might be, looked at what our facilitators and barriers might be. The next step is really then, once everybody is on board and everyone is on the same page, is really looking at those specific implementation strategies to get the job done, to get that theory in the guideline into everyday practice. So what we know from research is that when we use multiple strategies to implement a change, it increases the likelihood of success of that particular recommendation and its uptake within the clinical environment. So, for instance, sending out a one-off email or a 10-minute demo session, or maybe just one lunch and learn about how we're changing practice is not enough often to change the behavior and the attitudes and the willingness of staff to make some of those changes. So when we're able to sort of tailor some of those implementation strategies to staff and use multiple strategies, we know that success and uptake does increase. So this next chart here talks about, when we're looking at implementation strategies, what's generally effective in getting the job done and what really has little effect. So if we look at the far right column, what has typically little effect in terms of making a change or having staff make that change. Anything that's didactic, so a one-off meeting, a one-off educational session where there was maybe no chance to practice a new skill or ask questions, tends to have little effect on the behavior change of staff. And then, anything that's non-interactive, so whether there are potentially multiple education sessions, but there's not that opportunity to practice a new skill, to have discussion, to ask questions. Oftentimes we see that behavior doesn't often change. But when we look at then what's generally effective, again, it's implementing those multiple strategies. So when we have leadership buy-in at all levels, when we're able to embed the change into the process of our day. So we open up our client's chart and we let's say we're using electronic medical records, we open our client's chart, we get a pop-up window asking about our client status. And then we have templates that we can click and insert into the chart that will guide us through that discussion, whether for an initial discussion or a follow-up visit. That really does help to affect change. Things like audit and feedback. So having that goal of maybe having to start at least 50% of staff asking about a client's tobacco status within 60 days, and then being able to go back and run a report within the EMR to see whether we have at least 50% of staff at this time asking about tobacco status. We can then sort of celebrate successes, but also feedback to the team where we may make further improvements. Interactive education sessions, outreach, making it fun, you know, using different ways to market. So we're using education sessions, reminder emails, maybe there's posters, maybe there's lunch and learns. So we're using several different ways to promote that change. And generally we find then behavior is more likely to change. And when providing education or information to staff, just important to know that you don't have to reinvent the wheel. So for instance, at RNAO, we have many different resources that can be used by anybody regardless of healthcare setting. So if you're wanting to increase knowledge of staff using things like our e-learnings, we have 5 different e-learnings on our website, tobaccofreerNAO.ca. on a multitude of different topics, and those can certainly be accessed by staff for further information. And those e-learnings are designed to be completed in less than an hour, and you're able to sort of work at your own pace. And then, of course, we also have our print materials. So we have print materials just in regards to the brief intervention, the 4 A's of smoking cessation, and then we have more focused print resources specific to prenatal and postnatal women and their families wanting to quit or reduce smoking. And then we have another resource, which is our nursing faculty education guide. And that's for anybody working in a post-secondary setting who is interested in really embedding tobacco cessation best practices within nursing or other healthcare program curriculum. Being able to provide students with the knowledge they'll need to implement best practices once they're in the workplace or even as a student within their clinical environment. And also can be very helpful to network with other organizations who might be in your same geographic area. We're doing this, what are you doing? Do you have a good handout that talks about this? Because I haven't been able to find one. So being able to share resources and knowledge amongst different healthcare organizations can be really helpful. And then looking at evaluation. So oftentimes this can be a component that is missed or maybe not the same attention paid to evaluation as the other steps within the process. But always important to, when we're thinking about starting a cessation program or we're looking at increasing or improving our cessation program, to talk about like what are some of those goals that we want to achieve with our program, and then how can we evaluate whether we're actually achieving these goals. So there's different things to evaluate. So there's monitoring the knowledge used. So are staff now asking about tobacco status? Are they now documenting? Are they now implementing the 4 A's? And then there's the other side, which is then evaluating the impact on the client themselves. Are we seeing more repeat visits or follow-ups for cessation? And are we seeing smoking rates, tobacco use rates decline over time? So this slide just talks about some of those categories where evaluation might occur. So structure evaluation is evaluating, do we now have the correct or the needed required number of staff that are available, trained, and comfortable in implementing brief tobacco intervention with clients at this point in time? Do we now have the maybe exam room space, office space, large room space to hold group sessions at this time? The process evaluation is looking at whether and how the new practice is being implemented. So it's looking at potentially evaluating education sessions for staff. It's looking at seeing preliminarily have there been some changes in practice, and then that outcome evaluation. So what is the impact of this program now, for instance, on clients? Are we seeing more clients come back for follow-up visits? Are we seeing more clients start to reduce or stop their tobacco use over time? So it's important to sort of define what it is that you want to know, what are your goals, and then having that sort of evaluation plan in place from the beginning. So evaluation may occur in a number of different ways. So there might be surveys to staff or clients, chart audits, again, just running a report if you're on electronic medical records to see the number of staff who are documenting cessation attempts or cessation status, but also focus groups with clients, observing staff in terms of what they're doing, in terms of asking clients how that interaction is going. Are they asking about tobacco use with clients? Are they documenting? Are they arranging follow-up? So any of these strategies may be helpful in documenting whether these changes are occurring over time. And then finally is the sustainability piece in terms of tobacco cessation program. So it's looking at really, we've now gone through all of these steps. We've implemented this program and it's up and running, and we've evaluated. We know staff are on board, that they are documenting, asking about tobacco use, holding maybe group cessation sessions. They're able to dispense nicotine replacement therapy. But then when focus shifts over then to other priorities within the organization, how do we ensure that what is being done continues to be done as we go forward? So if you're able to sort of embed sustainability into your program, that certainly does help. So things like embedding the importance of tobacco cessation within your organization's vision or mission statement, within policy or for staff, that maybe there's this expectation that once a year staff will do a brush up in terms of brief cessation intervention. So the expectation once a year, I'll view this maybe 10-minute video or read this particular document to just brush up on my knowledge around brief cessation intervention. Is it part of the documentation process? So whether electronic or paper charting, are there the templates there? There's the expectation that every chart has been labeled in terms of whether the client uses tobacco or not. It's also part of the orientation process. So new staff coming on board will have to receive orientation around brief cessation intervention. So it becomes part of daily practice. It becomes part of the expectation of each staff member. It may also be embedded to things like accreditation as well, or some of those reportable fields that maybe managers need to report to the ministry. It may also be linked to things like performance evaluation. So are you in fact implementing brief cessation intervention as part of performance evaluation? So if we can sort of make it key to the everyday workings of the clinic, of the unit, and of the expectations of staff, it's more likely to continue going forward. So just in conclusion, just wanted to stress the importance of identifying from the onset all the activities and actions that may need to be taken to start or grow an existing cessation program. Also important to identify who, if we're developing an implementation team, who is going to carry out certain activities within this team. Setting specific timelines as well can be really helpful. So by X date, we're going to have completed our gap analysis, and then by this certain time, we're going to have completed our stakeholder analysis. And when are we going to complete certain maybe education sessions for staff? So having guidelines and being able to stick to them or make changes as necessary to those timelines can be important. as well as communication. So communicating the plan and its status to all relevant stakeholders. So nobody takes too kindly to somebody coming to you and saying, you're doing it wrong, we're going to start doing things this way, this is the expectation, go, right? So being able to be open and transparent with staff about why we're making these changes, getting their feedback in terms of what they see as important when making these changes, and then communicating and updating them along the way, along this implementation path, very important. As well as monitoring the degree of progress as we go along and developing any contingency plans. So if certain roadblocks come up along the way, what are we going to do to manage them? And then looking at identifying policies, procedures, orientation programs, et cetera, to ensure that sustainability does occur and that the program is successful and continues over time. So that's sort of the bulk of the content for today, and I apologize because it really is a brief overview of those 6 steps. So I do encourage you, if you would like more information or more explanation, to take a look at our toolkit, which again is available online as a free PDF. If you just Google the name of the toolkit Implementation of Best Practice Guidelines, you'll find it come up. Another site I found a bit helpful as well is the KT Clearing House. So it's the Knowledge Translation Clearinghouse, which has a lot of information about how to take sort of theory and put it into practice. And then the book I had mentioned where our knowledge to action framework diagram comes from, which is Knowledge Translation in Healthcare Moving from Evidence to Practice, is another helpful resource as well. And on top of that, as well, if you're looking for more information around guideline implementation, we do have some upcoming champion events. So we have our virtual learning series, which is actually on May the 17th, and you can register online for that. And then we also have full-day in-person workshops upcoming, which is our full-day workshop around the toolkit itself and delving a little more deeply into each of those 6 key steps. So we have one coming up on May the 25th in Ottawa and on May the 31st in Scarborough. And you can register for any of these upcoming opportunities through the events page on our website. And then if you're just looking for more information specific to smoking cessation itself, we have another webinar coming up on May 17th, and this is where we're going to focus on that Nursing Faculty Education Guide, or NPEG as we call for short, where we're talking about that particular resource and how we can start implementing tobacco cessation best practices within post-secondary curriculum. So whether it's nursing or other health science curriculum, that's sort of a step-by-step guide to implementing that with our students. And then we've got another webinar coming up in June. The final date hasn't been determined quite yet, but it's entitled Why Genes Matter in Tobacco Addiction, Unraveling the Secrets of the Double Helix. So that should be interesting. Keep a lookout for that one. And just in order to keep up to date regarding any of our upcoming tobacco and nicotine related events, you can check out our Twitter, which is hashtag TobaccoFreeRNAO, or our website, which is TobaccoFreeRNAO.ca. So if there's any questions, I'd be happy to answer them at this point in time.
So thanks for that wonderful presentation, Jennifer. I think you've done a great job in giving us an overview of the toolkit and really how it applies in a context of tobacco cessation or tobacco harm reduction. So we haven't had any questions as yet, but let's see if anyone posts a question. Maybe in the interim, you can just talk to us a little bit. You mentioned about stakeholder analysis and the importance of thinking about, are these stakeholders someone who's going to help us or hinder? What happens if they don't get along? So they're helpful for our purposes, but as 2 separate individuals or groups, they don't quite see eye to eye. How would you work with that?
Yeah, that can be a difficult situation where you may have stakeholders whose personalities don't mesh too well, and there may be some conflict there. I think it's important just to sort of remind everyone why we're here, that we're all working towards a common goal, sort of reminding them what that goal is. I think sometimes if things are quite tense, sometimes a strategy that could be used is maybe talking to the stakeholders separately. So maybe getting feedback from one on the telephone, let's say, and then getting feedback from the other on another telephone call. Sometimes that can sort of help if really not much is getting done because of the conflict that's happening. Or sometimes just really having face-to-face meetings. Sometimes if communication is done via email or sometimes even over the phone via teleconference, sometimes it's not quite as personable as those face-to-face meetings. So sometimes trying to incorporate some face-to-face stakeholder meeting may be helpful as well, because sometimes things can be misconstrued via email or maybe through the phone, where they may not be if these meetings are happening face-to-face. So that's another strategy potentially as well.
Great, thank you. I think you're really emphasizing the importance of really trying to find that common ground and work from that place.
Yes.
Another question we have is just, we tend to think of the toolkit in the context of helping our patients, our clients, our residents. We're wondering if the same approach can be taken for workplace cessation programs, policies. Can you comment on that?
Yes. So we were talking about today implementing those 6 key steps within a healthcare setting, but oftentimes individuals are looking at implementing a cessation program within a private workplace. So maybe potentially in a factory or in another private industry. And yes, absolutely, I would say that all of these 6 key steps, so regardless of whether you're implementing it in a healthcare setting or a workplace, a non-healthcare related workplace setting, certainly these steps can be helpful. You'd still want to do things like that gap analysis and looking at stakeholders and even thinking about documentation and policy and those sorts of things as well. So definitely that toolkit and these steps can be used in that environment as well.
Great, thank you. I think you're really indicating the just the use of that toolkit and those approaches beyond just a healthcare setting, but to other settings, and for not only for those we care for, but also for ourselves potentially. So I don't see any other questions. So I think at this point, well, thank you, Jen, again, for the excellent presentation. And just a reminder, so via email, you will receive, everyone who has attended the webinar today, an email from us within the next 24 hours, and it's a short evaluation survey. We just ask you for some feedback as we want to keep these webinar topics relevant for you and your learning. Once you've completed the survey, then you're able to print out a certificate of completion if that's something that you need. And again, we thank you for attending today's webinar. And please continue to check the Tobacco-Free RNAO website for any upcoming events and webinars. We always have lots going on here. And again, so we thank you, and we wish everyone a great afternoon.
Thank you. Bye, everyone.
Bye, Jen. Thank you.